If you see in those three key areas, or the four if we include our liver enzymes, if you see a few different problems, if you see high blood pressure and you see that your triglycerides are elevated and you see that you have insulin resistance or prediabetes, automatically you know you've got metabolic syndrome. And so you are at greater risk for heart disease, strokes, and diabetes. And so you want to take a more aggressive approach at getting to that underlying metabolic dysfunction that's causing all of those conditions.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you both.
To see you
Hello.
too.
All right, today's episode is all about knowing your numbers. And when we say numbers, we're talking about all the different ways that doctors can assess our health and what our body is doing. So this is going to be a really cool episode because my eyes glaze over when I hear phrases like A1C. I don't know what that is. I hear it on TV all the time. My A1C is great. So this is going to be a great episode. So Dr. Cooper, let's talk about just kind of what are the basic numbers that you look at as a doctor that treats metabolic syndrome and dysfunction?
Well, the main ones that I think are the most important have to do with the risk of diabetes and heart attack and stroke, basically, because those are kind of the number one thing with metabolic dysfunction. So thinking about diabetes risk, there's really at least two numbers that are the most important, and probably three. So fasting glucose, which most people are aware of. Fasting glucose means your blood sugar, basically, when you're fasting overnight.
And explain that because we've talked about that on previous episodes. Why is glucose in the bloodstream? What does it do?
Glucose is what gives our tissues energy to do whatever they want to do, whether it's our muscles or you're trying to walk or run, our brain trying to think. And so glucose is a really important fuel. And the other marker that we want to test is, if possible, although it's harder to kind of get doctors to order this as a test, so you might have to advocate for this, it's insulin, fasting insulin levels, because glucose and insulin work together. The insulin actually helps that glucose get to the tissues that need that fuel. And so looking at the two together gives you a lot of insight about how not only what the levels are, but how the insulin is working to deliver that glucose to the tissues that need it for energy. And the third one for the diabetes risk is the HbA1c, which is also, the full name is hemoglobin A1c, but it's also nicknamed A1c. You may hear that terminology. And what that refers to is it's a single number that reflects the average glucose levels over the past 3 months. And it's just on a single test on a single blood draw. And so those three markers give you a sense of insulin resistance, prediabetes, and diabetes risk.
So A1C is long-term blood sugar level? That's what
Exactly. It is. And the way it's measured, it is, as I said, called hemoglobin A1c. Hemoglobin is part of our blood count, and it's our red blood cells are involved in the hemoglobin production. And hemoglobin in our blood is saturated with glucose to some extent. And those levels, our red blood cells last for about 120 days. And so by measuring the percent of glucose that is attached to the hemoglobin, you can get a sense of the 3-month average glucose in the body. So it's kind of amazing that they came up with this methodology.
Why is it important for you to do the fasting insulin and the fasting glucose?
It's really important to look at those two together because if just having an elevated fasting glucose doesn't really tell you the reason that it's elevated. If you also incorporate the fasting insulin, you get a little more insight into that. On the flip side, if your glucose is normal, that doesn't tell you that there's not a problem going on. So adding the insulin can help identify a problem before it gets to prediabetes. So there's a ratio that is considered optimal between your fasting glucose and your insulin. And so mathematically, we look at the calculations of that ratio and we can determine whether your body's producing an excess amount of insulin relative to that glucose, which would indicate that your insulin isn't actually working that well to try to drive that glucose in the cells, or if you're producing an insufficient amount of insulin to the glucose, which would mean now your glucose might be driving up into a prediabetes range because your body is not producing enough insulin to help transport it into the tissues out of the bloodstream.
That's really interesting. And then we should also say that when we go in for our labs every 4 months or so, we do the fasting blood draw and then we have a meal and then they take blood 30, 60, 90 minutes after to see how those insulin levels react and how the other, how the blood sugar reacts, right? Everything.
Yeah, it's being that adds additional. Now, this isn't something that this is a little bit more advanced. So when we want to know our numbers, starting out, we want to know the fasting glucose, the fasting insulin, and this hemoglobin A1C. In our lab and for our patients, we do a more detailed where we also look at some of the relationships between that glucose and insulin after eating a meal. So, in what's called the fed state. So, not just the fasting, but the fed also. That's a little bit harder to access that information on a general basis. But if you can, that provides also some very good information about how you're processing the food that you're eating and if your insulin levels are responding normally to a meal and if your glucose levels are staying within an optimal range after you eat.
Right, you get to see if your body goes crazy after you eat or if it's doing the right thing and what your metabolism is doing when it sees food.
Yeah, because with diabetes, often what will happen is after eating, your glucose can normally there's a curve where it goes up and then it gradually comes down. And with diabetes, it can take a really long time for it to come back down and reset back to the baseline level. So it's nice to be able to see what is going on there before someone ends up with full blown diabetes to see any clues in that area.
Hmm. Okay, let's move on to blood pressure. That seems to be a really important benchmark to take care of high blood pressure because I've had friends who've had massive strokes, and I'm guessing that sometimes is related to blood pressure, right, Dr. Cooper?
It is. The most common cause of strokes is really a combination of high blood pressure and high cholesterol plaque buildup in the arteries. So that combination is the most common cause of what's called ischemic stroke, which is the more common type of stroke. But definitely, elevated blood pressure can lead to all kinds of things. It can cause dilation of your blood vessels, like your aorta, and it can cause, as we said, that stroke risk. So we definitely want to pick it up. One of the problems with the blood pressure guidelines is that not that long ago they were revised and they've become very strict. So we are detecting more and more hypertension in the population because of this revision of the guidelines. So people that previously were told, oh, your blood pressure is great, we're telling them, well, those numbers now are interpreted differently. And now we know your blood pressure is actually in an elevated category or in a stage 1 hypertension category or a stage 2 hypertension category. So the numbers are pretty strict. So I think at the low end of the cutoffs, we have to really look at the patient individually and see if it really does represent a problem or not, just because they are so strict. So now, if your systolic pressure, which is the upper number, um, that if that pressure is above 120, you're automatically in an elevated blood pressure range. And we used to think 120 was good. And then if your diastolic pressure is 80 or higher, you're automatically now in a hypertension range. So
Wow.
120 over 80 is not just elevated now. It's in the stage 1 hypertension. So if you have 120 over 70, it's elevated. So it's kind of, that's what I mean, is that when we look at our actual patients, we still, as clinicians, we don't take it that serious. Like, we wouldn't put someone on blood pressure medicine with a blood pressure that low, because then their blood pressure might end up too low.
Mhm.
But we might implement some lifestyle strategies to try to see if we could calm down that blood pressure. So again, talking about, as we talked about it in another episode, stress levels, getting adequate sleep, even things like EPA from fish oil can be helpful, making sure that your potassium levels are good. So just like evaluating, is there anything, are you taking maybe anti-inflammatory medications which can aggravate the blood pressure? So when you're in those kind of low to elevated ranges, low, slightly elevated ranges, we would implement those lifestyle strategies, because those cutoffs are really, really strict.
Wow. I thought the 120 over 80 was a good thing. That's now a bad thing?
Yeah, that's now getting flagged. So, but of course, we don't look at it the same way as we would if we saw someone that was like 145 over 90. That's clearly hypertension that needs attention, and medication, most likely. We do wait for a few repeated blood pressure measurements to decide whether to treat with medication. So it's good to monitor. If we do see an elevated level in our clinic, we do suggest people do obtain a good high quality blood pressure monitor and do some readings on their own. But you have to be careful about how you measure to make sure it's accurate.
That's really interesting, and your blood pressure can wildly change throughout the day. I remember I was driving to go give blood in downtown Seattle, and it was raining, and I was late, so I was stressing out. And I got there, and they took my blood pressure, and they said, "We're going to give you a couple of minutes, and we'll take it again." And they took it again, and they're like, "Oh, I'm sorry, you can't give blood today because your blood pressure is too high."
Yeah.
And it was like 155 over something because I was all stressed out. Now, obviously, Dr. Cooper, my numbers now um, are extremely, wildly, amazingly low. But yeah, just living proof that, stressing out and just throughout the day can really impact that blood pressure.
It can. And we have trouble in our clinic because people are fighting traffic getting in, and that's where we're measuring it. And we try to do the normal protocol that you should do, but it's often kind of rushed, so you don't always get to do it. But the typical protocol we should do to get accurate blood pressure readings: sit in a chair with your feet planted on the ground. Ideally, empty your bladder before you measure, before you sit
Mhm.
down, if you can, and just rest for a couple of minutes, just sitting, so that you're not just recovering from running up the hallway or running up the stairs or something. And try to get those levels as accurately as possible. Having the right size cuff makes a big difference. If you're using a cuff that's too small, it will definitely read higher, and that won't be accurate. So the cuffs are marked to show the proper length of the cuff, and so just make sure that it's the correct size.
Right. Because if you're bigger, they always have to go down the hall to get a bigger cuff, and then that's pretty stressful.
Yes, that is a stressful thing.
In terms of cholesterol, everybody always is talking about, I have high cholesterol, I have low cholesterol, I have no cholesterol, I have particles, I have little particles. What does it mean? Because I know that personally, I was always told, oh, you have low cholesterol, you can eat eggs and butter. And so that was great. But then we discovered through doing multiple cholesterol tests that I have something in my heredity that is these tiny sticky things that you have to do one more test that isn't always tested. That's a sticky particles. What's it called? Sticky,
Yes, that
sticky goo. I have some kind of sticky goo that you have to do one extra test that is not always in the tests. And so we do that test. And I went to a heart specialist and we're monitoring it. But all my other cholesterol, like if I did a regular cholesterol panel, everyone's like, whoa, look at you. Fantastic. Except for this one number.
It's a very good example. And even the opposite can be true. You can have terrible looking, what we call surface numbers, which are the routine ones that everyone checks. So it's total cholesterol, LDL cholesterol, which is nicknamed the bad cholesterol, HDL cholesterol, which is nicknamed the good cholesterol, and then the triglycerides. Those make up the main elements of what we call surface markers. So those numbers you want to know, but they're not enough. Just like Andrea was explaining,
Right.
in her case, the numbers were great, but there was actually more risk than those numbers let on. And in other patients, you may have terrible looking numbers on the surface, but then when you look deeper, you see that it really isn't a risk. So it's our standard way of measuring, but it's not enough to really see and determine the risk. So what we do is we take those LDL, the LDL cholesterol, and you want to try to break it down further to look at what are called LDL particle counts. So you're trying to see how many particles of this LDL do you have in a given amount of fluid that is in the sample. And the more particles you have, the higher the risk, because that would indicate that the particles are small. And the small particles are the higher risk. So this is where people get confused, because usually we're used to thinking if things are larger, they're higher risk. But here we
Right.
have small particles and they actually are very dense. So when they are in our bloodstream, they don't float as much. They have a high density. So they actually fall and can kind of sit on the artery walls. And that's one way that plaque can form if the conditions are right for it. Whereas if the particles are large for LDL, they're much more buoyant, kind of like a helium balloon that travels through the system and doesn't deposit into doesn't participate in this plaque formation as much. So those are things to know. And the typical test that will tell you the particles. So you want to ask for, instead of just a lipid panel, which is just those surface numbers, a more sophisticated test. There's several different ones. Some are called the NMR lipoprofile, the cardio IQ test, the Berkeley panel. These are all, there's one called the VAP panel, VAP. So you could ask your doctor for a more detailed lipid assessment that tells you your particle counts for your LDL. And that's a good place to start. The other marker that I think is gaining popularity that is very important to know is one of those genetic risk markers that can really increase your risk of plaque formation by about 30% if it's elevated. It's called lipoprotein A. And that runs in families. And unfortunately, it's not modifiable through diet or exercise and standard cholesterol medications. So that would be good to know, because if you knew you had an elevation there, then you would want to be a little bit more strict about where you want those LDL particles to be and where you want the rest of your cholesterol panel to be, because those numbers are changeable with either medication or sometimes with lifestyle strategies.
And plaque, by the way, is not like plaque on your teeth. It's gooey.
Yes, exactly.
Who knew?
Yeah.
I didn't know. I didn't know. I thought it was like hard, and then I was going to get hardening of the arteries and die.
Well, it is actually. It does become hard. Or there is an association. It starts out where there's like potentially soft plaque, and the
Right.
soft plaque is actually a little more dangerous.
They said it's more dangerous when it's gooey and soft.
Yes, and you know why?
Because it blocks everything.
Well, it can break off and float around.
Oh yeah, that was
Yeah.
what it is.
When it becomes when it's more calcified, when there's more calcified plaque there, it's considered to be more stable. and it
Yeah.
doesn't move around or break off as much and have that risk of obstructing an artery as it floats through your coronary arteries.
Right. Isn't that worse? Oy.
Wow.
Can we talk about the confusion about the good cholesterol, how it's bad, but the bad cholesterol good? Like, that's always very confusing
Yeah.
to me.
Well, we've tried to, use this terminology. LDL is the bad cholesterol, HDL is the good. But they found over the years, and it's now been, over many years, probably, gosh, almost reviewing the studies from the past 20, 30 years, they've found that the HDL cholesterol, which is nicknamed good cholesterol, is not protective the way that they thought it was against heart disease. And so we've tried not to use the terminology good cholesterol for HDL, but having an abnormally low HDL actually is a sign of risk towards diabetes. So people that are a higher risk for metabolic syndrome, prediabetes, diabetes tend to have low levels of the HDL cholesterol and high levels of triglycerides in their cholesterol panel. So if you see that pattern where the level's low and the triglycerides are high, the HDL is low and the triglycerides are high, it's a clue that person has a risk of developing diabetes, prediabetes, and they may already have insulin resistance or metabolic syndrome.
Wow, that's interesting. We should probably cover BMI because that's a number. And how do doctors calculate that, Dr. Cooper, and why is it important?
That BMI is a real problem. That
It's
measurement.
a torture number.
Yeah. Well, it is the relationship of height to weight. And
Hmm.
the same equation is used whether you're male, you're female, you're an athlete, or you're not an athlete. So obviously, it's not really very accurately predicting your health, looking at the quote BMI measurement. So, I mean, you can have Olympic athletes in a quote obesity BMI range because they have a lot of muscle mass, so they weigh more in comparison to their height. And so you don't want to ever look at that BMI as an indicator of your health. I mean, it is something we use in medicine to kind of just get a checkup on where are we with that height weight ratio. But then there's so many other factors you have to consider to determine whether that means that the person's body fat, for example, is elevated or their muscle mass is deficient. So it's not as valuable as something like body composition. And the body composition testing is a little bit more tricky because it's prone to misinterpretation. So I think that when it comes to that BMI, I would just take it with a grain of salt, the measurements there, and think of it as another data point. Don't beat yourself up over it or anything, but it's not, a really reliable indicator of whether you're healthy or not.
Well, it's pretty depressing though when you get your report from your physical or from your doctor visit, and it's one of the first things that they put on your notes, and it says morbid obesity on the top of it. And you just like, if you have that issue, all you can see is the word morbid coming like at you. It's really not a good thing.
Yeah,
That's my
I
opinion.
agree.
Yeah. Oh man. And that it's not super accurate. That's a little troubling as well.
Mhm.
Andrea, as you were going in and out of diets over the years, I'm guessing the scale was sort of everything, right?
Oh, up and down, up and down. And my mindset sometimes was fairly unreasonable as to where I thought it could go. And sometimes reasonable. I mean, sometimes it was normal, but sometimes it was really unreasonable. And, you know, you're in a contest sort of with your own head of how low it's sort of like a limbo. How low can you go? Um, and you have an unreal expectation. Look, you grow up in a world of images and magazines. I've always been influenced by fashion. I love fashion. I love looking through pages. And reasonably, yeah, I know I'm never going to be some kind of fashion model or whatever, but you think, oh, if only, if only, if only. So you you starve to go to that. And those weight numbers are your indication of how low can you go. And it it's not a good thing. However, and you know it's reasonably in your brain. I'm not a stupid person. I know
Mhm.
that that's not a good thing. However, it's like, how low can you go? And you think there's like a reward system in your head of like, oh, if only I could be that, it would be so good.
Yeah.
But
Yeah.
it's not a great thing.
Yeah. And Dr. Cooper, that pod that I went in that one time, that's the where you get into this little machine and they close the door, and that actually measures very accurately the lean mass and body fat, right?
Yes, that does measure it. And it is really interesting. So, this is another area in medicine that's just so faulted here because we've got all of our standard guidelines and our standard tables saying what the quote healthy body fat percentages are, what the healthy body fat percentages are. And then we have what is actually determined by the CDC as what is existing in our population. So they could not be further apart. So
What are the quote unquote healthy numbers supposed to
the
be for men and
oh,
women?
it's unbelievable. Men are really treated harshly by those tables. They're, I mean, I saw the tables are saying that men over age 55, if your body fat percent is like 23 or 24% or 25%, that you're in the quote obesity range. That
Wow.
actually is a fit male is in that at age
Hmm.
55. So it's just so far off. And some of the levels that they say are like the athlete levels are really unusually low. They're so low that they don't correlate clinically. If you saw a patient like that, most likely they do have malnutrition or
Yeah.
hormonal problems. So I think that they're just so unrealistic, all of those tables. And so then when you look at what the CDC says exists, everyone is in the obesity range according to those tables. So they're just not accurate. And so I think that leads trainers, that do a lot of the body fat testing, they kind of use those tables and they may report to the patient these unrealistic, nothing against trainers, but I'm just saying they may not be aware that those are not realistic numbers that they're using as their references. And so then patients hear that, and that's where a lot of the unrealistic um, targets that patients have for themselves come from as well, and unattainable targets.
When it comes to A1C, what's a good number? What's a diabetic number?
Yeah, and so that's a great question because the what we want with the HbA1c normal is considered 4.8 to 5.6. If you're anywhere in that range, you're considered normal. If you're at 5.7 to 6.4, that's in the prediabetes range. And then 6.5 and up is in the diabetes range. And if you're above 7.0, it's in the uncontrolled diabetes range. So those are the numbers for HbA1c. For fasting glucose, below 100 is considered normal. And then from 100 to 125 is considered prediabetes. 126 and up is diabetes. So
So
those are,
we should define, Dr. Cooper, I think, pre-diabetes and diabetes. So correct me if I'm wrong, but as the pancreas starts to shut down and create less insulin, then your blood sugar goes up in the body and you can't regulate your blood sugar very well. Is that what's going on? The pancreas is sort of slowly dying in its ability to create insulin?
that's the most common cause of type 2 diabetes. But there are other causes less common, but that is the most common. And it's also referred to as beta cell failure. Beta cells are what cells in the pancreas produce the insulin. And a lot of our current medications that we have kind of rescue that, and they help your pancreas generate brand new beta cells and start producing insulin again. So that's really groundbreaking that we can actually reverse the process of this beta cell failure. But yes, it kind of leads to what happens is the insulin, the most common progression to prediabetes and diabetes involves something called insulin resistance. And what happens there is that the insulin, which is supposed to be delivering that glucose to your tissues, such as your muscle tissues, is unable to like really force that glucose into the tissue. And so then your pancreas starts to pump out more and more insulin to try to drive that in.
Uh,
And after pumping out more and more and more insulin, the receptors for the insulin at the muscle cell level become more numb and they actually respond less to the signal. So then it pumps out more and more and more and more. And it gets to the point where it really exhausts these beta cells and they go into this failure mode. And so, one thing that's a very good indicator if we have patients that come in with diabetes and they're still pumping out insulin, that's great because it means, okay, they have the resistance component. So the insulin's not working, but they're still producing insulin. So they have a higher potential of reversing the disease than people who come in and their insulin levels are really low.
are there other numbers we should be tracking when it comes to our health, Dr. Cooper?
The most important ones I feel are those groups: blood pressure, your lipid panel, including the particles, and your glucose, insulin, and your A1C. If you know those markers, you can pretty much tell where you are in terms of the major health risks. Of course, you want to keep up with your screening tests for like cancer screening and things like that that are recommended at your particular age group and your particular situation. But these are the core numbers that should be part of every physical. And if anything comes back out of balance, you don't want to wait a year to retest it either. You want to keep a really close eye on it.
The big deal is the reaction between all of these numbers and how they all work together and how they play off each other.
Yes, it's true. There probably is one more number that we should consider, which would be looking at the liver enzymes for any sign of fatty liver disease. And so that would be, they're called ALT and AST measurements. So those would be good to include as well.
Would that be in a typical panel?
That's in a typical panel that you get called a comprehensive metabolic panel. Those are common panels that are run on routine labs.
So the real way that we can see what's going on with metabolic syndrome is how all these numbers play with each other and how they work together.
Yes, because metabolic syndrome is what we call high risk metabolic dysfunction. So you can have metabolic dysfunction without metabolic syndrome, and that could lead to obesity and it can lead to, diabetes without other conditions and things. But metabolic syndrome implies that there are multiple things going on in different areas at one time. And together they increase the risk of heart attacks, strokes, and diabetes. And so if you see in those three key areas, or the four, if we include our liver enzymes, if you see a few different problems, if you see high blood pressure and you see that your triglycerides are elevated and you see that you have insulin resistance or prediabetes, automatically you've got metabolic syndrome. And so you are at greater risk for heart disease, strokes, and diabetes. And so you want to take a more aggressive approach at getting to that underlying metabolic dysfunction that's causing all of those conditions, instead of just maybe taking a blood pressure medicine or a cholesterol medicine. Not that you may need to, but instead of just doing that and thinking you've solved the problem.
And I know from personal experience, Dr. Cooper, that my family doctor looked at these numbers sort of separately. And separately, they weren't really a crisis, but collectively, when you started looking at the numbers, you could tell that I was headed in the wrong direction and we needed to intervene to treat that. How should we talk to our family docs if maybe they're not super up on metabolic dysfunction and syndrome, Dr. Cooper? I guess we really need to be our own advocate, right?
We do. And I think maybe just even using that terminology and say, well, do you think I have metabolic syndrome? Now, unfortunately, sometimes the providers assume metabolic syndrome means obesity or something. That's not what it is. But maybe just bringing it up with them and seeing if you can have a conversation around that. One of the issues is certain blood pressure medications and certain cholesterol medications actually aggravate metabolic syndrome and make it worse, and push the patient closer to prediabetes or diabetes. And so it is pretty tricky, but I think just starting to have a conversation and see if they know much about metabolic syndrome. And you could just say, hey, I see that I've got these problems in these areas. And I've heard that if you have a group of these problems together, that it's metabolic syndrome. And should I be more aggressive, or should I do more screening for my cardiovascular? What should I do? And metabolic syndrome is recognized by the World Health Organization and by the National Institutes of Health and by the American Heart Association, the American Diabetes Association. It's recognized throughout the world. It's not controversial at all. So I think that bringing it up might spark your provider, if they're not familiar with it, to kind of look it up and maybe read a little bit more about it.
Well, this has been super enjoyable. Knowing our numbers. It's a big part of knowing whether we're healthy, whether we're headed in the right direction. Andrea Taylor, Dr. Emily Cooper, thanks so much for being with us. And this has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.